Okay, let's start with Monica. Give me updates on what you've been doing.
Good morning, Dr. J.
Can you guys always close the door when you're in the room? That's
Sorry.
because we have other faculty members.
So last week there was much about the abstract submission that we did until Thursday. After the abstract, I just got to the lab today, but I'm planning to work on the EDW starting today.
EDW?
EDW project. And he is
So,
working on.
so for the radiomics, so I want you to all know, abstract is really my way of trying to help you guys succeed. We do not need abstract. I do not need any abstract. Abstract is really considered preliminary. Okay, it's good for people who are in training. It shows how much they have worked. In the academic world, the currency is paper. So you have to have a solid plan to write a paper. Okay. So unfortunately, we've seen so many cases where abstract is done, but it was never turned into a paper, which is a tragedy. And I've even heard a case where, there was a really good candidate, did a lot of work, and the program director said, we're not going to give any interview. There's so many abstracts, but there was no paper. So this shows that this person done a lot of research, but wasn't able to finish their work and turn that into actual paper, because it takes a lot of work and dedication to write a paper. Abstract, they know it's just like, couple paragraphs and you're done. Okay. So I want you to focus on paper. Never think that, well, abstract is done. Now I'm going to do something else. Okay. So that person didn't get any interview because that's what the program director thought. You have to have a paper at least to be able to invite it for our program. Okay. So the bar is going higher. So uh so with that, what is your plan for publication, Monica?
Probably, yeah. Starting writing up, like you said.
So tell me the plan. What is the project and who's doing what? And you're kind of in charge of radiomics. So how many patients, what data, how are we going to frame it? And I can give you feedback, but you need to have like a whole big picture.
So
So
until
maybe Liam, you can help. Tell me about the overall picture of the radiomic, where we are. And when Dr. Jian was here, we discussed the big plan and how we're going to write the paper project and what are the pieces we've been waiting for and all that.
So we actually, in terms of the manuscript itself, as far as I'm aware, we have a rough draft that's almost ready. We were waiting for the finalized results to come in with the updated numbers, and we're also waiting for the harmonized data, which we have for this time around. But we have, I believe we have like 10 or 15 or so patients that we have to finish doing quality control and updating results for. They were like 10 or 15 patients that were excluded for the current AACR abstract analysis because we didn't have the time to do like a final update on just a handful of those patients. So I believe the next step would be to finish updating and finalizing that data set. And then asking Dr. Yuri to run the analysis one last time and give us all of the harmonized versus non-harmonized data. Dr. Chian and Taegyu, when they were here and before they left, they were able to put together a rough draft, but we're mainly waiting on the results to come out. And once we have the final like quality controlled data, I think we can ask Dr. Yuri to run those analyses one last time and use that information to finalize the manuscript and start the submission process.
So that will be the first radiomics paper.
That will be the first, yes, manuscript for radiomics.
Because we started with Dr. Jisang and it's always been the abstract.
Yeah, because the numbers were so small and we were never able to get all of the DICOM files.
So are we done? Are we waiting for more patient or are we like not getting any more patient?
No, this is it for now. So for this initial like radiomics project, we've received all the DICOM files. We just have to update like a handful of patients that had quality control issues. And we should be able to finalize this project. And then the next kind of radiomics / pathomics project will stem out of the EDW, the neoadjuvant, adjuvant, palliative, those cohorts.
So how many total, the first radiomics?
Monica, what's the final total number? I think it's like 160 something.
Yes, 160. And after we finish with the quality control, I guess we will have 174.
174. And did we discuss, are we going to do response or a pneumonitis? Are we gonna combine it or separate it? Did we discuss that?
My understanding is it was going to be one paper. I'm not sure if there's enough content for 2 separate papers.
I mean, it's exactly same cohort, right? I think it can be one paper.
And
Okay.
for the manuscript level, did you also want to put in like genomics prediction, like Dr. Chisan did in his initial abstracts?
Like a biomarker?
Biomarker predictions.
I think we should because it's the most comprehensive paper.
Okay, so we'll request that analysis to Dr. Yuri as well.
But everyone have undergone harmonization this time, right?
Yes, we have the results of harmonized data for response and pneumonitis.
Okay. Okay. So we'll work towards that goal. And so, Monica, I know Liam is helping, but you are the radiomics lead. You need to have a timeline. When are we finishing writing the manuscript? When are we submitting? To what journal? You probably remember that Seyoung did SOP. You have to write it in the Google Doc, who's leading what part, how many total. So make sure you have a SOP, send me the Google Doc, and you can have that reviewed by Dr. Liam. And for every project you're involved, make SOP. Make sure, even if you disappear tomorrow, everyone know exactly what to do, what's the timeline of the project, where it has been presented to, where it's going, who's been assigned to what. Everything has to be written, okay? Like a diary, okay? So I want you to, if someone asks you, tell me about your project, you can talk about it for a full hour, okay? That's my expectation, that you're devoted, that you know ins and outs and the big plan. So, so I would say the target journal, we can have it JITC as a first paper, journal. And then the title of the project is Radiomics Model to predict durable response and risk of immune checkpoint inhibitor associated pneumonitis would be our title for now. And then it will be the full 170 plus patient. Dr. Yuri needs to so the key is, now that we have enough patients, we had less than 100 patients before, we're going to need, just like what the Picture Health showed us, the training set and the validation set within our cohort. And then we're going to need to draw the AUC curve and everything that Picture Health did. We're going to do it with the Dr. Yuri's paper. So I would say this is 100 times more important than the abstract. So let's work full force on writing the manuscript. And like I said, Monica, you are in full charge. And I would say we would have the first full draft, I guess in 1 month, okay? And the full draft is there is initial draft already written. We're just gonna need to adding a few more patients that Dr. Yuri run it. So you'll really have to go and meet him, and this is the final, this is the way we want it. And Dr. Chisang did the biomarker analysis. So you have to understand what that is and how we can replicate that with the new data. And make sure Dr. Yuri runs it. And we should have the initial draft before Christmas break. And the hope is really to and then the writing the manuscript requires a lot of time, like looking at the literature. So this is something that MD or medical students can't do. This has to be done by medical doctors. What is the literature out there, and how is our data? The AUC is 0.6 at best. What does that mean? What are other radiomics group reporting? And then how accurate is the pneumonitis prediction and all that? And then we are flexible. Let's say during all that, pneumonitis has interesting result, and there's very interesting subgroup analysis that we can do, and we can separate the paper into two. Okay, just keep in mind, we're going to look at what data comes out and try to see what how best we can present data. But this is a hot topic right now, and time is of essence right now. So let's work So EDW is really important, but the priority for you, Monica, is writing the paper. Okay. And if there's so the project lead's job, and Liam is you're overseeing everything, but the project lead, what I hate is like, oh, someone else is doing it, and it's the ball is on their court. And you kind of wait forever. No, your job is make sure you go and meet that person, bring a coffee. Is there anything I can help you? Or should we divide and conquer? Is there anything I can help you? You do that almost weekly basis, okay? And make sure the piece is moving. Otherwise, it's stuck. You know, we have so many projects like that. So for the radiomics piece, if Dr. Yuri's the bottleneck, go and find him, meet him every day. If someone else is bottleneck, like if Yu-chan is not uploading, ask Yu-chan, like, can I upload this with you? You know, what can I do to, you know, move this process, okay? So project lead's job is really to make things move forward, work with everyone. And that is the most wanted skill set we need in the field of research. Not do your own thing in your own silo, okay? We have too much people like that. Like, oh, like, you know, that's not my part of my job. That's not like I'm just waiting for that person. No, it doesn't work that way. And so Monica, I want you to step up as a radiomics lead and try your best to finish writing the radiomics manuscript. And you have people around you who can help you, like Liam, and we have Seungmi coming next week. She's also a really good medical doctor from New York. So she can help you. Uni can help you. You know, you can always ask for help, and Dr. Yuri is always your best go-to for ask any questions. And then also Dr. Seong is not doctor yet, right? She's not graduated yet. So Seong is applying for the 1-year position in our lab. So Seong will continue to work with us. She told me that she's applying for it this morning. So hopefully the position will get filled, but by her. But she will continue to work with you, Monica, on the radiomics project. So yeah, definitely work with her to get this done. So let's aim for the initial draft before Christmas, and then go from there. Okay. And in the big picture is that's the stage 4 radiomics. The next one is Picture Health using their own algorithm and see how that algorithm performs. That's another paper. And then we're gonna send all the DICOM file to Lunit because they're not now interested. So Liam, please, you know, work with Lunit to make sure they receive all our DICOM file. I know we have to process all our things first and then share with Lunit, and kind of explain them what our data set looks like, and then sort of plan meetings with their radiomics team. They have a different radiomics team than pathomics team. So we're gonna do that with Lunit. And then these are, remember, stage 4. We want to know what's going on with stage the neoadjuvant group, adjuvant group, concurrent chemoradiation group. So these are the groups that we need to find. It's like a gold mining. That's the EDW project. And again, finding out where they are in their journey of cancer treatment is really a job of physician to find out by reading the charts. So that is what it is. Okay, Monica, any questions?
No, Dr. J. I will
Okay.
discuss with Liam once he gets here and then we get started.
And you can ask me any questions about the EDW, radiomics. Like I don't know what's tumor, I don't know this regimen. Bring all your troubleshooting questions to me here, but review it by Liam first, because he probably knows a lot of answers. But if he's like still, unsure, then bring it to me here. All right. Thank you, Monica. Eileen is here. So how are you, Eileen?
Hi, sorry, I couldn't come today because I actually flew back home for Thanksgiving break yesterday night. So I still wanted to give updates though. So regarding the sorry, oh my God, my loss of words. Regarding the variant classification project, I know we just had a discussion on this Zoom about taking more initiative, and I wasn't able to do that, so we are still waiting for gene analysis on the Fathom data. But once that is done, I just have to input the values into the manuscript,
Okay.
and then it will be submitted.
Okay.
For Pacemaker's interview, Miss Katie Dauble, who is from the Huffington Post, like there was an article about her. I think Dr. Liam sent me her information, so I contacted her. I haven't heard back, but once that's complete, I'll work on the video. And also, I
So
had
she didn't reply yet?
not yet, but hopefully soon.
How did you reply? Get in touch with her.
I did email. Do you think phone number is better, like texting?
Email. Yeah, email is okay. If you don't hear, give her some time.
Yeah, for sure.
Yeah, so maybe like after Thanksgiving, if
Oh
she
yeah.
doesn't reply,
I'll follow up again.
yeah, send another email and text her. Oh, I sent you an email. Was wondering if you got my email. I'm a student of Dr. Che, whom you met at it's called Target Cancer Foundation. Okay, that's where I met her. I don't know if any of her talks are on YouTube, because she is a very good speaker.
Right.
And that, Huffington Post is good, but like listening to her talk live, she's Kate Doble, so they're Incredibles. They write
Oh.
wear that costume, Incredible.
I had also contacted Dr. Pedro and sorry, I forgot her name, but she's from University of Utah. But the woman from the doctor from the University of Utah actually got back to me, and she said she's unable to give an interview. And Dr. Pedro, I'm still in the process of continuing.
Who said unable?
Let me find her name again. Dr. Eun-Young Park.
Oh, Eun-Young Park. Okay, yeah, maybe I think she wants to do it later. So yeah, just forget her at this moment. Yeah.
Okay. And then other updates, I guess. Last week, I was helping like Will with like the EDW first screening stuff, which I think undergrads are helping with right now. And I know in a previous lab meeting, you had mentioned to look for journals that we can publish the Pacemaker's manuscript to. So I found a couple, but I don't know if I should run that by you or through Dr. Liam, maybe.
Hold on. I found one of her talks here.
Oh, okay.
Listen to it before you interview so that you know what to ask.
Right.
I'll put it in the chat box here.
And for her, would we want to do faith-based questions as well, or?
No, just regular.
Thank you.
No problem. So what was your question again?
I know that you had previously mentioned to look for journals that we can publish the Pacemaker's manuscript to. So
Yeah,
I did find some, but I didn't know if I should run that by you or by Dr. Liam.
yeah, run it by me. Can you tell me what the candidates are?
Okay. Um,
Or can you share a screen and
yeah,
show what they
I
are?
can type the list in here.
Hmm.
I don't know if any of these sound familiar to you.
Hmm. Hmm. I didn't know there's a journal of patient experience. Wow. This is
I think there's like a journal for everything now.
wow. Wow. Patient education and counseling. Hmm. Preference and adherence. Medical humanities. Huh. Liam, any thoughts?
So I think they're all decent. And we had a couple of journals that are more high impact that we had previously collected. So if you're okay, I think we can start like with other papers. We can start with the highest impact vector journals and kind of work our way down.
Sounds good. Yeah, I just wasn't sure if there was another list.
So you have another list.
Yeah, there was a journal, but then these are definitely more like much higher impact journals. Um, like the ones we're more used to for the other kind of scientific manuscripts we submit at at our lab. So like
What are those?
JITC, JCOPO, like those journals.
But this is pacemakers, right?
Yes.
So I don't think that those journals will take those our project.
So like so we're in our previous research, we're thinking like maybe it could fall under like survivorship category, but
Mhm.
I do think it's going to be too high of an impact factor journals.
Yeah, so it's not scientific, it's more sociology. It's pacemakers. So there's a Journal of Clinical Oncology Practice, JOP. It's ASCO journal. See if they take anything like you can email the editor. Do you take these in an like abstract them? This is something that fits your journal. So JOP is what I would recommend. Any other journal I mentioned, Liam?
So let me just quickly share screen share.
I can't remember what I said.
And this was the list of journals that we had compiled at the very beginning of the Pacemakers project.
Oh, there's a supportive care in cancer. I think we talked about that.
Mm-hmm.
Oncology Nursing Journal. Can you show me that journal homepage?
This one.
Yeah, supportive care in cancer. Physical, psychosocial, spiritual aspect of patient's journey from diagnosis through the end of life care. I think this would be good.
Okay, should
3.1, hospice and palliative care. I mean, it's not hospice, but it's everything. Multi, yeah. So let's put this as number 1.
Okay.
Show me the other titles. There's clinical MD-Edge. Psycho-oncology. What is psycho-oncology? Mm-hmm. American Psychosocial Oncology Society and British Psycho-Oncology Society. Psychological, social, behavioral, and ethical aspect. Your families and caretakers, psychosocial, behavioral, that may influence the disease process. What is the impact factor?
It's 3.6.
Let's email the editor. Let's put this as another number 1. So yeah, let's email, and then I don't know if they're interested. Let's look at the Journal of Cancer Survivorship. Meta-analysis, clinical investigation, prevention management. Life of cancer survivor. So this is more like cancer survivor, but we're dealing with more patient with active cancer. So I don't think this is it. Can you go back? Can you go down? What is Journal of Cancer Education? Cancer education. Can you show me? Effective education about cancer-related issues. What does it say? American Association for Cancer Education. Cancer education. I don't think it's the right fit. Irene, can you share your list? Let's look at the one you found.
Oh, my list is just like on my like computer notes, which is why I just copied and pasted. I don't have
Oh,
links,
oh, in
but
the
I can
chat room.
find them
Okay, okay.
according to the ones that you're interested in.
Okay, I'm looking at the chat box again. Journal of Medical Ethics, Patient Education and Counseling. Journal of Health Communication, Patient Preference, Journal of Medical Humanity. Communication in Healthcare. Okay, I would say just by the title, Journal of Medical Humanities, Journal of Communication in Healthcare, and are the two ones that I would be interested in. So keep that as a list number 3 and 4 potential.
Okay.
And when we get there, we'll revisit, which journal. And I think we won't lose anything. You can email all the 4 journal editors and
Mm.
just send them our title and abstract. And would you guys be interested in this topic? We don't have to submit. We just know they are the right fit. So just send it to the 4 journals and yeah. And are you done writing the paper?
So I didn't realize that over the summer because I wasn't here in the summer, but I think Grace and Jessica finished it, I believe. The end part or the beginning.
Yeah, so we have a draft.
Yeah.
They're just working on the second draft basically, and the second draft isn't ready yet. But we have the abstracts.
So what's needed to get it ready?
So I've touched base with Grace and Jessica last week. They're just trimming, cutting down on the word count. Most of the journals are asking for either like 3,000, 2,500, and we ended up writing 6,000. So there's just a lot of cutting that they're working on.
Cutting? Well, okay. I mean, we can find that. I mean, we can find a journal that is more, accepting of longer article. We can even do open access journals if you find one. Like, I don't think this is good fit for scientific reports, but if you find clinical oncology journal, yeah. So maybe Liam work with Eileen to find a better journal, but among the ones you showed, those are my thoughts, but I know trimming it down is another tremendous work. So yeah, work on it. And this has been taking too long. So we should really aim to submit it, same thing, before the end
Sounds
of
good.
this year.
Mhm.
Yeah, so, and then it requires editing. So keep showing me the draft so that I can give you feedback and you can work on it and all that. So right now, who's working on it? Is it Eileen and you and
So right now, Jessica and Grace are working on it.
Jessica and Grace? Okay. Is Eileen involved?
Not as of right now, but we can definitely have her get involved.
But were you involved before, Eileen?
Oh, yes.
I was involved before, but I didn't know, or I wasn't present in any of the lab meetings, so I wasn't coming to see like what was happening. So that's my bad.
Oh, okay. Yeah. Because I think you were the one of the initial members. So keep working on it and yeah, divide and conquer. Jessica and Grace, you said?
Yes.
Okay. So Eileen, well, obviously Liam is the lead, but yeah, work with them. Hold on, I'm getting a call.
Thank you. I'm actually interested in the topic that you're doing. Can you teach me what's the project that you're going to do?
The one we just talked about. Hey, Eileen, are you still there?
Hello, sorry, I had to step away for a second.
Oh, no, that's fine. Did you hear Dr. Unhi's question?
No, can you repeat it?
Oh, so basically Dr. Uni was just asking if
Yeah.
you can explain this pacemakers project.
Yeah.
I wanted to, yeah, why don't you give it a shot?
Okay. So basically, Pacemakers, it's an organization that we founded here in Lab, and basically, like the main point of the organization or the movement is to kind of find ways to creatively encourage patients and their caregivers, and also like other healthcare professionals who are supporting these patients throughout their treatment journey. So we have like a website and like a YouTube channel where we do like the interview videos of interviewing like patients, their caregivers, healthcare professionals. And basically this project was we're trying to write a paper on it and like how we can kind of how do I explain this? How we can kind of support them through like pacemakers. So the paper is just analyzing how pacemakers can help doing that like through like creative encouragement, whether that's like providing like awards and like that type of thing. We also talk about like different themes like support network, solidarity, that type of thing. Yeah, I don't know if there's more to add. Sorry, I can't think off the top of my head at this moment.
That pacemaker website or YouTube video, is that a purpose for teaching doctors and like caregivers?
I wouldn't say the website is necessarily for teaching purposes, but it's kind of, I can show you the
Okay, then one of my patient having stroke symptoms, so my nurse practitioner called, so. Yeah, I'm always on the, people can reach me 24/7, because like my patients are in ED, my nurse practitioner, pharmacist, everyone wants to talk to me, reach out to me. Really, you know, if you are attending, if you're a hospitalist, if you're working in ICU, if you're working in ER, you have your pager. It's on, you go home, off, okay? If you are oncologist, you're 24/7 on, okay? They want to talk to you. People in outside ER doesn't know you're on vacation. They will still page you, okay? And my stance is, I don't care if I'm on a Caribbean cruise or in South Korea. I would rather have someone call me, page me, text me. I'll answer right back because I know best about my patient what to do. If it goes to someone who's covering me, they're gonna have to go into Epic and read everything and understand the patient again. And so it's such a long I've been on the other side, so it's best that I would definitely give you know my direct guidance whenever I can. If I can't, just wanted to tell you guys, being able to be reached is the key for any clinicians. Like, oh, I can't reach that doctor, and that rumor goes around that that doctor is very difficult to get hold of, doesn't answer return pages. It's a really bad reputation. It's gonna ruin your career. Okay. Referrals won't come because people know you're a bad doctor. And I've seen it happen in many people. So respond always. Respond quickly. Research questions, okay. There's no urgency. Clinical research, there's urgency. But patient-related issue cannot wait. Cannot wait. I just want to emphasize that. That's why I give my cell phone number to everyone. Everyone, every resident, every nurses I work with, pharmacist. Call me. If I don't answer, text me. Because I'm in a meeting, I can still text back. Sometimes they call me for, acute stroke. Of course, they have to call me. And document. The other piece is always document. If you talk to the patient, document what time would you talked. This is the instruction. Patient refused something, document. Okay. It's so important. Okay. All right. Those are my 2 cents. So I was telling Eileen, you should be the undergrad lead, and you should make sure Grace and Jessica does their part, finish what their piece is, and the lead in consultation with Liam gets to decide what you need to divide and conquer to get this actually to a publication quality article. And then you go through revision with me and submit. Okay.
Yep. I will follow up with Dr. Leon first.
Yeah. And so same thing, make an SOP, title, the first, what are the key journals, who are the project leads, who's taking care of what part, and for the abstract, where it has been presented to. Because some journals ask you, like, what year, where has this been presented, in what meeting? So you have to have all that information. So as a project lead, I want you to be in charge of everything about the project. Okay.
Also, sorry, I don't really know what a SOP is, but would that entail like making like a Google Doc type
Yeah.
of?
Google Doc, and
And-
and then the logistics. Talk to Dr. Liam.
Okay,
Yeah.
sounds good. Thank
And
you.
yeah, Monica, Eileen, everything you make, share it with me real time. Send it to my Gmail once you make those SOPs. Okay.
Okay.
Okay. Uni.
Mm-hmm. Can I share my screen?
Yeah.
So actually, like totally we got 62 patients, but like based on the criteria, there's many rule out patient. So we totally got like a little bit more than 30 patient, but these days I feel like I can speed up more. There are several questions for you. The first one is pneumonitis. So there was one patient who got ipilimumab, nivolumab, carboplatin, January 4th to February 5th. And then 1 month later, he was on a clinical trial with AMB 564. I'm not sure that this is an immunotherapy, but it's kind of immune modulator treatment. So pneumonitis occurred on in March, like early March. So it was like a 1 week after getting AMB 564. So I thought that pneumonitis likely coming from this clinical trial, and I put it into the date of pneumonitis here with the AMV 564.
What
But
is the agent?
the agent AMV 564?
Yeah.
1 second. So that was a CD33 CD3 T cell engager that binds CD33 on target cells and CD3 on T cells. The AMV 564 is the name of the medicine.
And is this the lung cancer patient?
Yeah. So I'm not sure, do I have to put the pneumonitis in this at this time, like with this regimen?
So this is called bivalent bispecific monoclonal antibody, specific monoclonal antibody.
Can it
Um,
be counted as immunotherapy?
Well, vaccine is immunotherapy too. Immunotherapy is very broad category. But if you say immune checkpoint inhibitor, there's no checkpoint here. Checkpoints are PD-1, CTLA-4, LAG-3, all these checkpoints, like breaks on the cell surface. CD33 is on myeloid-derived suppressor cells and leukemia cells. So myeloid-derived suppressor cells are the one that causes immune suppression. So if you engage T cells with CD3 and kill MDSC, then there's an immune boosting. So long story short, I wouldn't call this immune checkpoint inhibitor. And including this in our data analysis makes it challenging. Like, anyway, what is your question?
So is it okay for you to just put pneumonitis for each line, for both line? Even though I think that this pneumonitis is coming from the AMB 564, but are you okay to put pneumonitis to while the patient having 6 line of immunotherapy and chemotherapy?
In reality, I think both are possible.
Mhm.
AMV can cause pneumonitis too. Yeah, so this this is like, welcome to clinical medicine. Like, then how are we gonna code this? So in real life, this is what I do. I put this patient as a ipi-nivo side effect and do the analysis. And I include this patient in my whole analysis, and then I exclude this patient and see what happened. That's what I would do.
Okay, then I will mention that in the comments that later that you can like rule out this or not, like later that we can decide about it.
Yeah, but right now it's okay to include that as a 6th line side effect.
Okay. Next one. So progression. So I know that when we say progression and when we log the data of progression, it's usually based on imaging studies and based on the progress note when they how they assess or analyze that imaging studies. So there was a one patient who had a new RAD fusion mutation, and the note exactly says in that way that at time, so after they found a RAD fusion mutation, they switched the immunotherapy to selpercatinib, and at the time of progression, planning aging of this as a second line therapy. So in this case, do we say progression in this case? So can it include the liquid biopsy result? Or are we only saying progression based on the imaging studies?
Yeah, only based on imaging studies.
And there is some complex version. This is my last question.
Uh-huh.
So, the patient was diagnosed NSCLC adenocarcinoma and initially staged as 4B.
Uh-huh.
At the time, there was a right upper lower lobe mass with a hilar involvement, and there was a multiple like areas in the lung area, but they were not sure that whether that is really a cancer or not. So after have a long discussion with other specialty and with the patient, they think that there is no like definitive metastasis or distant disease, because lesions are so small couldn't do any biopsy. So they started to do systemic therapy with pemetrexed and pembrolizumab. And after the patient got 4 cycles, there was a notable response that there was to get near complete resolution. So after that, they decided to do a surgical resection of the lung. So my question is, when the patient got chemotherapy and immunotherapy, can we call this as a neoadjuvant, even though the initial proposal was a palliative, but can it count as a neoadjuvant and this surgical resection as a definitive treatment?
So after surgery, was there anything left in the body?
No. But later, yes.
M1C was due to what?
M1C, so there was a carvarium lesion, hepatic lesion. I forgot about it. But they weren't sure about M1C. When I read the note in the imaging study, they even didn't do any biopsy for that. And
so this patient is still alive?
yes.
Okay. So those M1C were never proven.
Never proven.
So I would consider this as a neoadjuvant case.
Okay.
And call it M0.
M0. Okay.
So in retrospective, it's M0 because it's not acting up.
Okay. Then if there is a future case like this, can I retrospectively like change the staging?
Mm-hmm.
Okay. So that's all my question. Thank you.
Good. I love those questions. So it's better than assuming. If you don't know, always ask. Like I said, tragedies come if you work with people who don't like to ask. Like if I work with an intern who doesn't want to ask, they make a lot of mistakes and never tell me, the senior residents, okay? Because they like to assume things. Sometimes they're just afraid to ask, oh, my seniors might be busy, you know. It's same thing with research. Sometimes the professors don't know, how the research was actually done because they don't tell their boss. And the critical error was found later on, and it's like, it's a responsibility of the whole lab. So we want to discuss anything that's unclear, any questions, and this is the time to do that. So thank you. So Lee, so Uni, you had question about, the process. Did Liam tell you the what you need to do? Didn't you have question about the EDW?
EW?
Yeah.
So
Did you
I
say Taha did something and you didn't know which patients that were, remember?
yeah, but I think like before I'm leaving, I'm gonna clear up the initial two doctors done. So after that, after starting cleaning the data, I will ask you again for the next lab meeting.
So let me ask Liam. So what's the process? Give me the overview picture of the workload and how many patients how many are done, and how many Taha did, how many is Uni's gonna do, like the big picture.
Sure. So Will has the accurate numbers. So we have the EDW data set that was queried. I think we got it narrowed down to like 2,000 after removing the duplicates. And the students are doing the first screening, and then the MDs are doing the secondary screening, where and basically the students are only doing what they're doing is they're basically screening for patients who received immunotherapy. So they're just going through the patient's chart and just seeing if immunotherapy pops up in their treatment regimen at any point in time. So if immunotherapy does appear in their treatment, then they just collect those patients. And then for the secondary screening, the MDs are receiving a list of patients, not NSCLC patients who has received immunotherapy at some point. And then the secondary screening entails the actual collection of clinical data and variables and filling out the Excel sheet with the clinical data. And so it's at that point where we're going to look at staging, the diagnosis, histology, the type of treatment, and then the category of treatment, like is it neoadjuvant, adjuvant, or palliative, or consolidation. And then this is the way and this is going to be the really rate limiting step for us at this point, because we have to do that for several hundreds of patients. Dr. Uni, do you know how far Will's gone through the first screening and how many we've done for the secondary screening so far?
So for the initial screening, Will already did 500 patients, and among 500, I think 440, we got 440 screened out. So that 440 patients is for secondary screening, which I'm doing. Jaha and Seong, maybe, they did around like 30 patients. both, I mean, not each, I think totally like 30 to 40 patients. But the problem was most of the patient they logged, they collected was not really in the that initial 500 patients list, I mean 440 patients list. So that was my question. Where is the total patient list? And for each, so I think for each patient, it usually takes like 30 to 40 minutes to 1 hour. So I think we need more people to be included in this research project to like clear all the 500 patients, I mean, at least. And also, Will is doing another like 1,700 patient, so it will be gonna add it up more. So I think totally to 2,200 patient for the second screening.
So maybe for this one, Liam, you should make a SOP. How many total first screening and the date? Maybe every week, give a number. How many screened? First screen, how many screened out of second screen? Let's track the progress. Who's doing what? Let's do a track board of who screened how many. I mean, we need some accountability here. Like we can't just say do this and do what you can, and there's no and you know, Taeyong found duplicate patients, so we need some innovation here. Like we need some smart thinking. What's the best way to screen these patients? And I know it takes time, but this is a necessary work of laying foundation. But we need clear deadline, we need clear goal, expectation, and you know, I think it's gonna have to be more work-based. You know, if you're assigned this number of patient, you know, you're responsible to finish it. And you know, what is a reasonable expectation? How long does it take? Everyone will have different you know, speed rate. So yeah, Liam, think about it and make SOP and share it with me. I'll give you my feedback. But this is a daunting task, and it has to be a shared work, communal effort. My concern is doing I mean, it can't be all equal quality because every MD thinks differently. Although we're telling them to troubleshoot, they might make mistakes. And it's not like we can go back and look at someone else that's going to supervise and re-review everything. It's impossible. So we're just gonna have to just really trust them. But yeah, Liam, it's your job to educate them, like tell them how to screen. But okay, so let me just at the big picture, right? So how many identified total and how many first screen happened? Is it like 50%? Is it what, 3,000 patient? How many total?
So I think Dr. Ni was saying the total number after removing the duplicates is about 2,200.
2,200. And then
then
how many did we screen so far?
Will did 500 so far. Like we did a total of 500 first screening so far.
500. Okay.
So we still have like 1,700 left.
Okay. And that can be done by undergraduate students.
Yes.
Okay. The second So 5 out of 500, how many second screening did we do so far?
Dr. Uni?
60 patient.
60 patient. And Taha Seong did 30
Yeah.
and you did another 30?
Yeah.
Okay. Wow. When you do second screening, are you recording PFS and OS?
Yeah. I'm doing all.
So that's why it takes longer time. So that has to be done by MD. So okay. So when Dr. Seungmi comes, when Dr. Andrew comes, they're gonna work on this EDW. They can help with writing radiomics paper if they want. They can make graph, they can write the discussion together. They can be part of our team, whoever comes. Okay. And when Sally joins, Sally will also be full-time getting the EDW, screening out, writing the paper, tracking down all the projects. So we'll have some efficiency there. Okay, but for Monica and Ani, this will be a great learning point for you because we have to get this written out. And there's a lot of clinical questions that can be answered. And can you close the door, Emily? So, yeah, refer to NCCN guideline if you don't know the regimen, and learn as much as you can about this is almost like you shadowing in clinic how these patients were actually treated. This is a lot of clinical wisdom. How do you manage side effects? So I do believe this is tremendous clinical pearls you can learn from these type of research here.
Dr.
Okay. Any
uh,
questions? Any?
Yeah, can I make a SOP for the second
Yes.
second-
Yes. That
Yeah,
would be really good. And
because
then combine it with yeah, and let Yu-chan with Liam make the first SOP. So Liam, you oversee everything. Make sure the first screening and second screening SOP comes out well. And it will be good because whoever will get involved in the future, they will just look at the SOP and understand the whole project. Okay. All right. Okay, Liam, update.
Yes. So I don't have much today. We were busy with the abstract deadline up till the end of last week. And afterwards, we've been working on the thyroid cancer case report with Dr. Eugene and Chu Hee. So we have that draft ready for you to review. Do you want me to share my screen or should I send
Yeah.
you the draft?
Tell me the draft, yeah.
Okay, so it's actually just a Word document, so
Word document, yeah, it's okay. So send me the Word document. I'll pull it up and I can. I get to get out by 10, so I'll still have time.
I'm sending it in the chat box here. So the first one that's sent is the editor's comments, and then the second one is the edited draft for you to review.
It didn't come yet. In the chat box?
Oh, sorry. I didn't send it to all. I sent it to just Eileen. Let me send it again. So the second one that's titled manuscript.
Okay. We got
So this is the editor's comments and our responses.
hmm. Why prescribe lenvatinib BID instead of daily? The lenvatinib was given daily. But did the manuscript say it was BID? So I don't understand why it was BID in the first place. I think it probably was an error. So look at the actual EPIC note and look at the medication, how it was prescribed. Verify. Maybe it was an error. I don't know where the error happened. So correct the error if it was error, and if you have any question, run it by me.
Okay.
Temsirolimus alone result in a similar as opposed to, so we don't know that. Unusual with Q6 dosing of nivolumab. So this is also an error. Nivo was given every 2 weeks. Ipi was given every 6 weeks. I don't know why people are making this simple errors. Why is comment 5 and 6 same? So if you look at the EPIC, the treatment regimen, Nivo is given every 2 weeks, usually fixed, sometimes with 3 mg per kg. Ipi is given 1 mg per kg Q6. So this is Checkmate 227 dosing, Checkmate 227. So you can cite that regimen, put the reference there, and that's usually exactly what we do in my clinic. So this is not a good answer. So thank you for your comment. Based on your comment, we made our manuscript more concise and to the point. Period. They're not gonna go back and say, oh, this part, you should change that. They're not gonna spoon feed you, okay? So do what you can. and say that you did it, and say in which part specifically, which paragraph, and just be very detailed. So that would be my comment there. See the manuscript here. Okay, let me go and close the door. I'll be right back. Okay, I'm back. Okay, now I'm with the paper. The response to combination of mTOR. Okay, here is the. So this paper has been out for quite a long time. When did we first submit this one?
Oh, this was
Hi.
more than a year ago.
Yeah.
Yeah, but we keep getting rejected.
Hmm. Right now, what journal is this?
That is a good question.
So maybe it will be a good learning experience for Monica and Uni. You both can read this, okay? And this is how we write case report. And this is one of the patient that was treated here in our clinic. And her name is Vivian Panu. And there's an interview, pacemaker interview of her. So if you read this and then read the pacemaker, it will be a great case learning case for you. I think her video had the highest number of views, right?
Yes.
She was a TV filmmaker or like the director of so she was well known in LA area. So here's TMB measured by MTM. So why is it TMB here? It's not tumor mutational burden. Tumor mutational burden is measured by number of mutation per megabase pair. So this is clearly a circulating tumor DNA, not TMB. It's measuring circulating tumor DNA, the amount of the DNA circulating in the blood. So TMB is not the right acronym for it. So please correct that. Okay. So this one, Dr. Eugene O, make sure you revise based on all my comments and submit ASAP. Okay. All right. Any questions?
Nope, I think that's it. So once we revise for your comments, are we good to just go ahead and?
Yeah, good to just resubmit.
Okay.
Don't wait for me. Anything else, Liam?
No, so that's it for this. And then, just a couple of questions regarding the meetings that we have scheduled for today and tomorrow. I don't know if you.
Yeah, everything has to be rescheduled.
So no meetings today or tomorrow. We do have Lunit on the schedule.
Yeah, so that's for you and Hesong to. I don't know if Hesong's done with her interview in the morning. You
Mm.
and Hesong can go in and kind of do more logistic follow-up.
Okay.
It's more about, logistics. How do you open it? Like, if there's any directional questions, just run it by me after the meeting.
Okay.
Text messaging. So for the Lunit trial, so we're gonna abort everything about, doing it pathcore. So let them know, Lunit has decided to, just send slide to Quest and let them scan it over there, not using our pathcore.
Oh, okay. So we don't have to work with our passport anymore.
Right. So just let them know that, that's just been changed in a direction.
Mhm.
But in terms of getting the slides scanned and everything, do you know if there's a Zoom call with Dr. Yal Dandy?
The pathcore person?
Yeah. Uh-huh.
I don't think
It's
so.
not pathcore. Dr. Yal Dandy is our lung pathologist. We're trying to work in place of Dr. Alex.
Oh, I don't think so. I haven't seen that.
So you are CC'd in that email. So work with Susie to get that on our book schedule. That's the most important.
So, yeah, just going back at the email thread, Dr. Yeldandi said Dr. Nizami, our molecular pathologist, will collaborate with you on this project.
Hmm.
So should we schedule a meeting with Dr. Nizami or Dr. Yeldandi, or both?
So I don't know what she means by will collaborate with you on this project. Does it mean she's not gonna be part of it, or?
Or maybe we can just schedule the meeting with Dr. Nizami first.
Hmm. We can still invite.
Okay, and Dr. Yeldandi can be optional.
Yeah.
Okay. Should this be virtual or in person?
Virtual. So just follow up and let's make sure we do this meeting sometime next week.
Yes.
So Lunit. So work with Hasong, finalize the synopsis. I need to send it to all the outside investigators.
Mhm.
We need to work with Lunit to see if we can open it in South Korea and work with Akiso Bio to see what needs to be done to have them ship the drug to South Korea. What are the regulatory barriers? So work with Akiso Bio on that. We need to finalize the protocol so that we can send it to our own IRB, SRC, and move it forward, and also have budget team review it and have budget ready.
Mhm.
So just make sure everything is moving. That's our number one priority. Last trial. What else? And for the DART capsule concepts, Biodesics, there's a Lunit one. Work with Katrina to set up the triage meeting, and it's been like a month and I don't hear anything back. So follow up with all the DART capsules.
Yes.
That's really important. What else? So I heard from OncoHost that they said our legal team is reviewing their budget.
Yes.
So follow up with them. I don't know why it's taking so long. So it's gotten to a fact that for the biomarker trial, Dr. Jyoti Patel said we're not gonna wait anymore. We waited too long. So she's just gonna open up her own trial and it's gonna compete with us. So I just don't understand this. I mean, but I feel like we have to just tell them this is priority. We have to open this. Where are you in the review? I don't know if you have been doing that weekly, do it more frequently. Like let's do it twice a week. CC me on every communication. Like they make them very irritated, so that they need to we need to just pound on them. I just don't know. I mean, at this pace, I feel like we can't do anything.
Mhm.
So really just CC me. I'm serious when I say twice a week. Send them email. We have patients waiting. We are waiting to open this trial, or start this, and we have deadline coming up for our first presentation. We need to get this started. Whatever you can say to push them. Any rate limiting step, whatever company that's holding up. Biodesics is saying the ball is on our court as well. Guardant is saying the ball is on our court. Whoever that person in charge is, find the person, email. If no response, find the location and go and meet. Like what can we help you? Yeah, but I think we really have to work on this, Liam. I feel like every project is in halt. So same thing, make a SOP. I know you did it for the biomarker trial, but do it for every company possible. Make a table. When was it halted? Who has it? When did you make the last call? The clinical trial office people email me. If I don't respond, they like fifth attempt, sixth attempt, and you haven't responded to my previous email. They just pound me, okay? They leave an evidence how many times I emailed. So I feel like we have to be the enforcer now, like really, I feel like nothing gets done. So that's the job of manager, like it or not, like we're the ones who have to move things. So I just wanted to let you know that I don't, so same thing, make a SOP for all company collaborations. Where are the contracts, legal reviews, whatever budget, where is it? When was the last communication? Just think of it as a diary, and make a Google Doc for that as well, and share it with me on a weekly basis, so that we know exactly by numbers where it is. I feel like we really have to hold them accountable. So send out all these emails today. So maybe have Tuesday, it will be the default day to, if the ball is not on our court, if it's on our court, we'll move it. If it's not on our court, we make sure it's out of their court. And I feel like we need to do better job here. Any comments?
No, makes sense. Yeah, we'll bug the contracting office and shoot for the budgets more often. I hope that's enough, like, because the answer that I keep getting is like they're backed up, they're short-staffed, and we're working on it.
Yeah, and we are asking for if like the rough draft or anything.
Oh, so
Uh,
all the the budget, like, he still has to work on it, but with the contracting piece, all the rough drafts have been sent out, so they're just going back and forth between the companies on finalizing the language. So it's just been a lot of back and forth with all of the other companies.
yeah.
So I know that, like, I check on the carries or series website, and like there is progress on a weekly basis where like someone from our end sends it over, and then they review it, and then they send it back, but just a lot of back and forth. And each time the legal department has to review something, or the contracting office has to review something, so it takes like a week.
Mm-hmm.
So yeah.
But I don't understand, like, since the beginning, it's taking too long. But that's that, but definitely follow up with the garden one, follow up with the biodetics is more cohort A, even that is in halt. And the garden is the whole another game. So follow up with each company. I think the person in charge for all those company are different.
Yes.
Yeah. Okay. All right. Anything else?
That's it. So did you want to reschedule the Lunit meeting tomorrow for the research grants discussion?
Is that a research discussion? I thought it was more logistic.
So I think today's one is the clinical trial. There's 2 meetings on the books.
Okay.
I don't know if you still see them or if they're still on, but there's one for tonight at, I think, 6 p.m.
What
And
is
that
this
one-
about?
So this one's the clinical trial collaboration. So I was assuming this is where we're talking about the clinical trials we have with them. Yeah, so today at 6 is the last trial discussion. And then
So I think this is more logistics.
yeah, so I think that would be okay.
So just do this on my behalf.
Sure.
Tomorrow is what?
Tomorrow's the research grant discussion at 4 o'clock.
Okay. So keep this on, and like I said, like, write a proposal, send it to Ken and Dr. Oak so that they have it before the meeting.
Okay.
And I'll try to be there as best as I can. If I can't, you can discuss it with Dr. It's logistics. So you can explain what we've done with other companies and we want same kind of support. I'll try to be there. If I can't, I'll trust you to be there on my behalf.
Okay.
Okay, so today there's some SIV, remote SIV, Terito Thomas, okay. Just tell, can you tell Susie to reschedule Dr. Terito Thomas meeting? Since I have to, work from home, I can't meet her. Can you do that for me?
Okay.
Yeah, we'll just reschedule that one.
Just that one?
Yeah, I don't think I have SIVs, if I don't go in, they'll reschedule it. It's okay. I don't think there's any other meetings.
What about the 1:30 Gardens? I don't know if that's still in your calendar.
Today?
Yes.
Oh, that's okay. I think that's for the whole group, not just me.
Oh, okay.
Yeah, I think that's it. So we have a plan and yeah, and then confirm when Dr. Seungmi is coming, maybe Monday late afternoon or something.
Yeah, I messaged her yesterday. I haven't heard back yet.
Yeah. Okay, guys, keep up the good work. I'll see you guys.
Okay.
All right, take care. Bye.
Bye bye. Thank you. Bye.
Bye.